All right, I don't have any financial disclosures. This work I'm talking about today, I'm doing in partnership with Co-Imagine Health, which I'll talk about briefly, and this is funded through the Utah Department of Health. And then the research I'll be presenting to you today is funded by the NIH through the National Center of Advancing Translational Sciences, through those grants listed there. All right, just briefly, my partner, unfortunately, today is not able to come in. She was sick today, but I'm working with Co-Imagine Health. For those of you who are not familiar with them, they're a nonprofit national organization that does a lot of work with health systems, clinics, hospitals, and so on to do healthcare improvement. And if you're interested in any of the work that we're doing today or some of the other things that are listed up there, please go ahead and contact Adrian or myself, and I'm happy to get you connected with them. They're a really great organization. They bring a lot of resources to healthcare systems. All right, objectives for today. So there are three things I wanted to cover today. One was providing an evidence-based, patient-centered approach to prescribing opioids to patients after surgery, describing the importance of getting people to dispose of leftover opioids after surgery, and then outlining some best practices around co-prescribing naloxone with opioids. All right, so everybody's heard of the opioid crisis. It's gotten somewhat lost in the context of COVID, but it's an ongoing crisis that continues to worsen. But I think it's worth taking a few moments to explore why it's important to us as providers and why we should care about this problem. So this article came out last year in the New York Times, and this accompanying graph shows the number of deaths from drug overdoses since 2010. And as you can see, it's been steadily worsening since that time period, and it's taken a real sharp upturn, and unfortunately shows no signs of decreasing. So in 2020, there were over 93,000 people who died of drug overdoses in the United States. And unfortunately, but not unsurprisingly, the CDC just released their latest numbers for 2021, and that bumped up to about 108,000 people. Just to give you some context for these numbers, let's see. We give you context. Let's see. Yeah, go ahead and click there. Okay, perfect. That we have far exceeded the peak number of gun deaths that occurred, which in 1993, peak number of gun deaths that occurred in 1995, or HIV deaths in 1995, and then I'll show car crashes if you hit next there. There we go. In 1972. So this is a major problem for the United States. And the important thing to know about the opioid crisis is we often hear about it in the news, and it's usually in the context of things like illicit opioids, lacing of drugs with like heroin with synthetics like fentanyl, and that is a major part of the opioid crisis. But if you actually break down the numbers, prescription opioids do contribute a large amount to this ongoing crisis. It's coming down in the last few years, but actually went back up in 2021. So in 2020, 28% of overdoses involved prescription opioids in some form or fashion. So as much as we kind of don't want to be part of this problem, we are part of the problem. And I'm just going to throw some numbers up. I'm sure there are numbers for primary care and other emergency medicine and other fields. But for surgeons, we are definitely contributing to the excess supply of opioids out there. So there's estimated probably about 64 million operations being done every year, and a large percentage of those patients, probably the majority, are actually being still sent home with opioids after surgery. If you ask them, about 60 to 92% of those patients have leftover opioids afterwards, and these are usually stored insecurely in your bathroom cabinet. I won't ask how many of you are doing the same thing with your drugs, or maybe it's a uniquely Utah phenomenon, but a lot of people are like, well, I keep them just in case I'm canyoneering in the backcountry and something happens to me, and I'm like that guy that got the boulder dropped on my arm, and I need those opioids, and so that's why I'm not disposing of it. But the reality is that this excess supply does cause problems both for patients, their friends and families, and their communities. So 2/3 of people who misuse prescription opioids get them from family or friends, so they're not getting them from the street. In addition, the initial exposure to opioids is often through prescription opioids, but then people who go on to use illicit drugs like heroin, this is often their first introduction and how they get started on illicit drug use. And this probably contributes to a threefold increase we've seen in the last 2 decades for children who are presenting with overdoses and poisonings. Again, probably because of insecure storage or lack of disposal. I think this excess supply also plays a problem in terms of how our patients use opioids. So I'll tell you, as a colorectal surgeon, if you look at our numbers, it looks like about 10% of opioid-naive cancer patients who are undergoing a colectomy or a low anterior resection or APR will go on to become chronic opioid users over 90 days. And I don't know if there are any thoracic surgeons out there, but you guys are responsible for that 15%. How many of you guys know the parable of the river? All right, great. I get to tell you something new. So this is a parable, I think, that really highlights the difference between healthcare systems and public health. So here's the idea. So imagine that there's a village next to a river. And so one day the villagers are out by the river, and they see a person floating down the river, and they're drowning. So what do? They mount a big rescue effort. They get in the water. They rescue the person. They get them out. The next day, there's another person drowning in the river. And so what do? They get ready, they get all the rescue operation going, and they rescue that person. And the next day, there's 2 people in the river. And so now they're a little bit taxed, but they rescue both those people. And the next day, there's 3 people, and 4 people, and 5 people. And pretty soon, they find themselves pretty taxed in terms of recovering. And finally, one day, somebody says, we should go upriver and figure out why these people are falling in the river in the first place, right? And I think that kind of summarizes our healthcare system, right? We are really, really good at fixing people with acute problems, and certainly that's true of surgeons, and bringing a lot of resources to bear, but we don't often spend a lot of time going upstream and figuring out what the causes are of our health problems. So just a few more numbers for surgeons, and I know there are not many in the room, but so I'm sure you guys have your own individual numbers that you guys are familiar with. But more than a third of the prescriptions we write for are for opioid prescriptions, and probably the other half are like, misuse of antibiotics, but that's an aside. We write for about 10% of all opioid prescriptions in the United States. So it's not the total, but it's a fairly large proportion of what we write on an annual basis. And 11% of overdoses that involve prescription opioids can be traced back to a prescription originally written by a surgeon. So we are contributing to this ongoing crisis. So let me jump in there. Let's see, here we go. Okay, so let me just kind of dive into some evidence-based data-based approaches to how we're trying to change the way we prescribe opioids. So if you're like me, many of you who trained during residency, nobody taught you how to write for opioids, right? For surgeons, certainly surgical trainees, the most important thing was that we wrote enough that the patient didn't call us back in the middle of the night, and they didn't call our attending back in the middle of the night, right? And then, we didn't want to have to go down and meet them at the front door for that paper script. That was really painful. And so we wrote for large quantities just because we didn't know what else to do, and we weren't told otherwise to do that. In fact, I would say that we're often encouraged by our attendings to just take care of the patient. In the last few years, there have been a number of guidelines published by a lot of different groups. So up in the kind of upper right corner is the Michigan Open, the Opioid Prescription Engagement Network, and these are their guidelines for some general surgery procedures. In the bottom right-hand corner is Dartmouth's guidelines, and you'll notice there that they actually base it on the day of discharge, and then also on how much the patient uses prior to discharge, and that helped guide them. They've further refined this, but I just throw this up as a guideline. And the other tables up there, just to show that there's some other guidelines for a variety of fields like gynecology and orthopedics, and this is the guidelines from Hopkins. So here's the problem with these guidelines. For the surgeons out in the group or anybody out in the group, you're probably going, you know what? I already changed my practices. I know the opioid crisis is going on out there. I've reduced the amount of opioids that I prescribe. And you're right. The truth is that most of the time we actually are already prescribing below those guidelines. So I did a study with a friend of mine, or a couple friends, colleagues of mine, so we did it from our data from University of Utah. We included Partners Health, so the entire Partners healthcare system, which includes MGH and Brigham and other hospitals there, and the Mayo Clinics, so quite a few health systems here. And we looked at 5 common general surgery procedures, and we consistently always prescribed under the existing guidelines that were already being published. But the kicker is that we were still prescribing 3 to 6 times as much as patients were actually consuming, so we're still leaving patients with an excess supply. When we drilled into the data a little bit further for the University of Utah, and I'm going to present some data around major abdominal surgery. So these are patients undergoing open colectomies, major ventral hernia repairs, pancreatectomies, things like that. We found some really interesting data that kind of has driven where we're going with prescribing. So the first is that many of our patients don't use opioids prior to discharge. So up to a quarter of our patients in the 24 hours before their discharge home don't use any opioids at all. Guess how many of them got an opioid prescription? Right, every single one of them. So the median was 8 oxycodone tablets. On the flip side, about a third of our patients had what I would call high opioid and pain needs. So they were using greater than 60 morphine milligram equivalents, which is about 8 to 9 oxycodone tablets in the 24 hours before they went home. The problem is that 82%, so almost all of them were given a prescription that would last them less than 48 hours based on their ongoing consumption. So we have 2 problems here. The first is that for the majority of our patients, we're over-prescribing opioids. But for a subset of our patients, partly because we're trying to cut back and we're trying to be responsible, we're probably underprescribing the amount of opioids that they need. And I think this is particularly true for patients who have chronic pain or on long-acting agents like methadone. All right, so this next table I'm going to walk you through. It's a little bit complicated, but I think it's worth digging into the data and kind of understanding how we've gotten to where we're trying to, the algorithms that we're trying to promote right now. So this is a little bit different group than the group that I just presented, but patients undergoing major abdominal surgery. And in the first row, what you see is the median number of tablets they were prescribed of narcotics, which was about 15. And then I'll just skip the second column for a moment. And then the third column was how much they consumed. So they only consumed a median of 3 tablets after surgery. And they had a median of 10 tablets left over. And if you tally up how much in this cohort of how many leftover pills are being generated by this during this time period that we studied the patients, it's about almost 700 excess tablets of pills that are being prescribed. Okay, so I'll just highlight there. Okay. The next 3 columns are sort of a hypothetical, like what if? So what if I took the same patients from the University of Utah, but I had followed the guidelines from Dartmouth, from Mayo, and from Michigan? And how would that change what was being prescribed? And overall, you can see that the overall amount of prescriptions as a group really didn't change in terms of the median number of tablets. You'll notice here that if I'd followed the Dartmouth guidelines, 24 patients who got an opioid prescription would not have gotten an opioid prescription. So I think overall that's pretty good. We'll just assume that they use the same amount as they actually reported to us for their procedure. And for the most part, the number of leftover tablets really hasn't changed that much as a group. And you can see that both in terms of the median number of tablets prescribed, as well as the total number of tablets that are sort of excess supply that's created during this time period. So one of my residents, Josh Bleicher, has been thinking about this a lot and doing a lot of modeling work. And we wanted to come up with an algorithm that was pretty simple, nothing complicated. You know, we can use machine learning and other things like that, but we needed something that was really simple that we could teach our residents and teach other people to use. And so we came up with something we call 2 times 24-hour PDOC, or 24-hour pre-discharge opioid consumption. So here's the idea. The patient comes into the hospital. Let's say they get a colectomy with me. And in the 24 hours prior to discharge, they use 2 oxycodone tablets. Based on this algorithm, we would discharge them home with 4 of them. And the key here is that if they use 0, we gave them, the residents and trainees and PAs, permission to give them also 0 tablets. And we got sign-on from all the attendings on the surgical oncology and the colorectal services to do this. And we also capped it at 30 tablets, with the idea being that if you're using more than 30 tablets, you should probably be calling us back so we can make sure that we're actually doing a good job of pain control, we're not missing something going on. And so this represents, again, a hypothetical application of this rule to our patients. And what you can see overall is that the number of tablets being prescribed as a group drops quite a bit. Now, the median prescription is now down to 6 tablets. We have built into there the idea of not giving them any opioids, so 24 patients, again, don't get any opioids because they weren't using any before they went home. And the median number of tablets left over drops quite a bit, as you can see both in terms of the median and also in terms of the total number. The thing that's kind of lost in this table, but is really important to note, is 14% of our patients would actually get more opioids than they were actually prescribed. So this starts to address this other side of patients who are being underprescribed, who have potentially real needs and may need to have some pain issues. So I'll just jump ahead and say that, you know, I'd love to say that at the University of Utah we're perfect and we're doing this every day and it's already set up. It's not. But on our colorectal and surgical oncology services, this is what we're moving towards, using this algorithm as a guideline to our residents and PAs and attendings for their prescribing. And it's not a hard and fast rule, right? So if they feel like this is not appropriate for their patients, for example, my partner who does a lot of HIPEX, the intraperitoneal chemotherapy, she doesn't want her patients to go on this, that's totally fine. If you think they need more, that's also fine. But the idea is to follow this rule, use this rule to get the residents and the PAs to look at what the patients are using before they go home and guide the discharge based on that rather than kind of on a gut feel. It's okay to prescribe no narcotics at all if the patient isn't using any. Capping the prescription size at 30 tablets. And there's no restriction on the type of opioid. So if you prefer oxycodone, you prefer Norcos, you prefer Tramadol, that's fine. We're also combining that with trying to improve our preoperative and pre-discharge education. I'll just say briefly that we've been doing study around this. The idea is this, you know, we all know that just giving a patient a brochure about being responsible and doing pain management and opioid management is not enough, right? We really have to follow best practices. So that includes repetition, multimodal education, tailored to their needs. And so what we do is we have our nurses in the pre-op clinic sit down with this brochure, which is put out by the American College of Surgeons, evidence-based, consensus-driven document. It's actually very easy to read. You can download it and distribute it for free. And we have the nurses sit and go through it with our patients before surgery, talking about what to expect after surgery in terms of pain and how they can manage their pain, not just with opioids, but with alternative methods. And then we repeat it. So before they go home, our discharge pharmacists, who are fortunately very engaged in this project, have sat down and show them the same brochure. They go through it, but now the patients have had surgery. They've been in the hospital. They know kind of what it's like to manage pain, and they try to tailor it to their needs while they're going over their discharge medications, especially if they're going home with opioids. Another thing we're using is logbooks. So, for example, kind of modeled on those of you who take care of CHF patients, keeping track of daily weights or keeping track of their dietary intake. The same idea is in play here. If the patients keep track of it, they're more aware of what they're using. They're kind of conscious of potentially cutting back. And it gives us a way to look at what they've been using over time. And I'll talk about Naloxone Co-Prescribing in a moment. So that's at least what we're trying to get into place as a system in our sections and ideally eventually across the University of Utah. All right, promoting disposal of leftover opioids. So this is a topic that I've spent a lot of time researching, and I think it's kind of the other half of the equation. So if the problem is that we have an excess supply of prescription opioids out there, reducing prescribing is kind of the big thing that we need to address. But the other half of it is that patients are going to have leftover opioids. We can't guess exactly how much they need. And the reality is we can't get rid of opioids entirely. As much as we want to move towards complete opioid-free surgery, that's really just not a reality for many of the surgeries we do. And so the idea is trying to help people get rid of the leftover opioids after they're done using them and they no longer need it. Just to say that this is not out in left field, I'm really excited that actually some people are starting to recognize this. So if you have any interest in the opioid crisis, not just around surgery, but just in general, I encourage you to look at this website in the corner from the Stanford Lancet Commission. They have some really good, thoughtful, evidence-based recommendations for policymakers and healthcare systems about how to address the opioid crisis. But I'll just highlight that one of the things they pointed out here was that we really need to do a better job of reducing the supply of excess opioid pills, and one of those is through disposal. So the reality is that if you don't do anything, most patients are not going to throw away their leftover pills. And the studies show only about 9% of people do that routinely. It's probably gone up a little bit with the as the opioid crisis has kind of gotten bigger, but I think it's still fairly low if you don't do anything. The problem is that most of our existing interventions don't work very well. So most of you probably have those drop boxes that are in those pharmacies that you see right there. And people really tout like, oh, we collected like thousands of pounds of drugs. If you actually go through and sift through all those pills, most of them are not controlled substances. I know some people do use them, but the majority of those medications are expired heart medications and other drugs like that. The DEAs had made a big point of these take-back events, and I should have looked it up for the Ogden region, but I'll tell you that if you search take-back day for drugs in Salt Lake City, what you get is April 20-something for every year. You can go to 5 or 6 different sites. These sites include like the county jail, like a couple police stations and things like that. And you can go between 10 a.m. and 2 p.m. to drop off your medications. And then that's just really inconvenient. And so if you actually sit down again and sift through all the meds that that are dropped off in this, and they'll tell you that there's like tons and tons of medications that are returned. Only about 4 to 12% are controlled medications. Again, the majority of those are expired heart medications. Patient education, so this is the standard go-to that we all use as healthcare providers. If I just educate the patient, if I give them a brochure, if I have my nurse talk to them, they'll do what I want them to do. And I know that doesn't work for most things, and it doesn't work for opioid disposal. So as a general rule, you see a little bump in improvement, maybe 8 to 20% increase in disposal once you implement some like an educational intervention like that. I think that 51% is a little bit of an outlier, but I just wanted to acknowledge that someone did get a pretty big bump in increase in terms of disposal from education. Financial incentives. This is actually a really interesting one, and one that I thought was going to work better. So the idea that has been floated around for a number of years now is to get somebody to pay for take back of these pills. And in fact, I think the Massachusetts legislature at one point was considering a bill to try to make drug makers pay for this. I don't think it ever went anywhere. But the idea is this, right? If you have leftover pills, what if I pay you to bring them back? And so the VA actually did this pilot study. They did it with veterans undergoing surgery, and they paid them $5 for every opioid pill you brought back that you didn't use, and they capped it at $60. And I was kind of surprised that only 30% of patients actually participated in this program. And it's probably too much for this talk, but we actually did a study trying to explore why this occurred. And what it probably comes down to is convenience. A lot of the vets in this study were from rural areas, coming from fairly far away, long distances to come in and travel, and so they were probably forgetting to bring them in, or it just was too much of a hassle to come back and participate in the program. And so convenience is a big driver, but financial incentives can work in sort of certain circumstances, but not as well as we think. The most effective thing, oh, you know, I left it in my bag, but I have one afterwards, or a picture of it next, is what we call home disposal kits. And so I don't know if you've seen these, and I'll show a picture on the next slide, but they're little plastic packets. And the idea is you give them to patients, and they're pretty inexpensive. You buy them in bulk. And patients can take their excess pills, at least the ones we use, can take both pills, liquids, and patches, for example. And you add some water, and there's something like kind of like activated charcoal in there, and it breaks down the drug, it neutralizes it, and then they seal it up and they put it away in the trash can. And the great thing about this is they can do it in the privacy of their home. It's really easy to use. When they see it, they kind of remember to do it. It doesn't contaminate the groundwater because it's in a plastic sealed bag, which I don't love, but it's, it seems to be a good thing to do overall. And you can't, like, if someone breaks in your house or goes through your trash, they can't get it back out. Like, in other words, they can't use the pills. And I think for all those reasons, these things seem to be pretty effective, at least after surgery. So our group, as well as a couple groups from other institutions, did some studies, and we see about 60% of adults who undergo surgery who are given one of these bags will dispose of their leftover opioids afterwards. And that's about a 30 or 40% increase from baseline. And if you give it to parents of kids undergoing surgery, almost 3/4 of the parents will use it. That's the wrong button. Okay, here we go. So what we've done with this, based on this data and some other data, is actually rolled out a big system-wide intervention at the University of Utah. So in August of 2020, in the midst of COVID, we actually started this program. And what it is that every single patient who's filling an opioid or benzo prescription at one of our pharmacies gets one of these bags for free, no questions asked. And they get some education around it. And we've been studying this for the past year or so, and I'm about to put out a paper about this. But essentially, we're seeing almost more than 3/4 of our surgery patients are willing to dispose. They either have disposed or will dispose using this bag coming up, and only about 8% are planning not to dispose. So there's some nuances here that we can do better around it in terms of text messenger reminders and education. But I think as a good first pass, these things do work, and we're starting to see that come up. I will say that the FDA is considering a public rule right now about something different, where they're talking about giving out mail-in envelopes that patients will get, that they mail to a facility. I have some reservations about that just because that hasn't been studied, and I think some people have some real hesitations, or maybe we'll just see an increase in postal truck thefts, but we'll see. Okay, Naloxone Co-Prescribing, the last thing I have. All right, so this is the idea. The idea behind Naloxone Co-Prescribing is that we should consider prescribing naloxone to patients that we're also prescribing opioids to at the same time. And this is particularly true, for example, high-risk patients, like our burn unit already does this on a routine basis. But it's something that I think all of us should consider more. And I will say that, whenever I bring this up, a lot of people go, well, I think of naloxone in the context of someone overdosing on the street who is at high risk. And I have to acknowledge that Jennifer Plum and Utah Naloxone and other groups have done a really good job of getting naloxone out there for those patients. And that probably is like the high-yield group that would benefit from naloxone. But there is some benefit for us as providers about thinking about co-prescribing this as well. So here's the thing. If you prescribe naloxone at the same time that you give someone opioids, the risk of opioid overdose decreases, even if the patient doesn't fill the naloxone prescription. And this probably is because the co-prescription serves kind of a purpose of both in educating the patients, so you're educating them about naloxone, and then thus you have to educate them about the risks of opioids. But it also reflects a culture-changing strategy about how we view opioids overall and the risks of opioids to patients. And the CDC actually has been recommending that we consider co-prescribing for quite a while, and this came out in 2016 in their guidelines. So who's at risk, and who should you consider co-prescribing for the patients? Well, the patients who have a history of opioid poisoning, intoxication, or overdoses, patients who are a history of other substance use disorders or opioid use disorders, patients who you suspect are using illicit opioids or non-medical use of opioids, or those who are taking it with benzos or drinking alcohol with their opioids. Those are patients that potentially could really benefit from naloxone. There's another subgroup of patients, those who are at risk of returning to a higher dose to which they're no longer tolerant. So maybe they were in prison, for example, and they're getting a very controlled set dose, and now they're back out in the community and potentially could access opioids off the street or through friends and family. Patients who are taking greater than 50 morphine milligrams a day, so that's 7 tablets of oxycodone. I'll tell you that there's decent percentage of my patients after major surgery who are maybe taking that at least for a few days. Those who are receiving rotating opioid medication regimens, this one I think I'll defer to those who are doing pain and addiction, but my understanding is that's when you're rotating the different drugs through to try to maintain efficacy based on the different drugs. Anybody on extended release or long-acting opioid medications, or anybody who's getting a new methadone or buprenorphine prescription for opioid use disorder. And the last one I think is kind of interesting. If you look through the guidelines, they're also recommending that we co-prescribe naloxone to patients with at risk of overdose because of their respiratory, cardiac, or renal disease, or those who are smokers. So how do you start that conversation? And I fully acknowledge that many providers here probably don't have time to add yet another thing to your list, but this is something I think your staff can do very effectively, and that's something that we're trying to roll out in our clinics as well. And it's important to counsel patients about the role of naloxone and the risks of opioids. And it's important to highlight to them that we're not targeting you just because I suspect you're going to be an illicit drug user or you're going to misuse it. That this is something that we want to everybody who's potentially at risk, just because of the inherent nature of opioids, to be aware of and potentially fill the prescription for. It's important to ask them what they know about naloxone, because most people have very preconceived notions about what it is. And ask open-ended questions, like what concerns do you have and what questions do you have about this medication. And I think this is really key, especially for those patients who are coming in with family and friends, especially at discharge, because certainly for surgery patients, they're usually being picked up by family or friends. So this is a great opportunity for education, to educate them about naloxone and when to use it, because really they're the ones that are going to be administering it. Just a couple things to think about language, because I think language is really important. The word overdose has a lot of negative connotations, not always. It's always kind of constantly changing, but it's something to be aware of. And so when you use the word overdose to people who are just using prescription opioids, let's say after surgery, they may not relate to that term. And so some better terms are maybe accidental overdose or a bad reaction or opioid safety. You can also talk about how opioids can kind of frame it in more layman's terms. Opioids can sometimes slow or stop your breathing. Naloxone is the antidote to opioids. Or I like this last one where you're talking about naloxone is to opioids like an epinephrine pen is to allergies. And so these are some of the strategies from that website listed there. A couple of things to remember for those of you who don't prescribe that often or certainly administer it. I think I last administered it when I was in inpatient setting and when I was a resident. Naloxone rapidly reverses the opioid overdose, blocks the receptors, and prevents the action of other opioids. It's safe, so if you give it to somebody who isn't having an overdose, nothing's going to happen. It only works for a short period of time, so that's that piece that, if you give it to the person who's overdosing, you don't just walk away. You got to make sure they get transported somewhere else, or be prepared for it to wear off, and then they might need a second dose or additional doses after that. But it gives you the time to rescue the patient. And this is, I think, the key. Naloxone is pretty widely available. You can get it through pharmacies, often without a prescription. You can get it through programs, the community-based distribution programs, like Utah Naloxone or local health departments. And cost may be an issue, and this is something we're dealing with right now at Utah. We're trying to increase our co-prescribing, but a lot of times insurance doesn't cover it. And so patients get to the pharmacy, and then they're told, oh, you got to pay like $40 to $60, which is more than paying for the rest of their meds, and they balk at that. And so that's, I think, an ongoing challenge that we got to address. I don't know that, I'm guessing all of us are probably on EMRs, but if you're on paper, this is what a prescription looks like. I just have it quick saved right now. And we often have a BPA that sometimes pops up that just you can click a button. I'm not quite sure how to trigger it. I wish I knew. And so that's it. These are the citations at the end of the presentation of all the papers I've talked about and some of the resources. I think it's probably in handouts if you guys need it. And if you have any questions, there's my address. And then my partners, if you're interested in any of the work we're doing around opioid stewardship, we'd love to talk to you further. Come out to your clinic or talk to your hospital. Co-Imagine Health are my partners, so you can email any one of us up there. So thank you very much.
Appreciate it so much. Yeah. Hold on one second. Are there any questions? That was an excellent presentation. Go ahead.
Yesterday, there was a pain medicine doctor that promoted buprenorphine as a primary pain medication. Have you looked into that? What's your take on that?
I'm going to defer to the chronic pain medication doctors on that one. Here. I know there's been a lot of changes around the waivers of buprenorphine, but yeah, I'm not aware of using that as a primary pain control. I think if you're going to use that, you should get someone who's waivered and comfortable with prescribing it, and I certainly am not as a surgeon.
Thank you. How does this all compare to fentanyl coming across Kamala's border? Could she get the cartels to put naloxone in the fentanyl?
So you're talking about synthetic, yeah. So I mean, I think the bulk of the opioid crisis. Let me, I mentioned prescription opioids is a part of this. Let's say about a third or a little less. But the bulk of the opioid crisis is really still issues like synthetic fentanyl being laced, lacing heroin, things like that. My understanding is you can essentially just order it online from China and other places that are being shipped in if you needed to get to it. So I think there's a lot of problems here. The bigger question I'll just throw out there from an opioid crisis, so this is the Parable River comment here, is that I don't think the opioid crisis is just about availability, right? I think there's a lot of issues here around what we call deaths of despair, socioeconomic inequality, people feeling like they're not heard, lack of access to mental health, lack of access to addiction medicine. So don't get me wrong, it's not just about limiting or restricting the supply. I think we have some really deep cultural and societal problems that we have not addressed at any level.
So occasionally, I mean, when I have a patient come see me in my family medicine clinic, they'll bring in their medications if they're on it, and we'll go through the medications. Sometimes they have an old bottle of opiates, and I want right then to just take it because they're not using it anymore. But you can't. I've been told you can't take it from the patient. But that seems like another opportunity for some sort of innovation. I don't know if you've had any thoughts or heard of anybody who's done something along those lines.
Yeah, so just a point of warning, if you take it and you advertise that the DEA will come and knock at your door. So that was actually when I first started. I was like, well, why don't we just take it back when they come back in? And so we talked to our pharmacist and we talked to the DEA, and they're like, oh no, you can't do that. It has to be registered, it has to be put in a lockbox, it has to be a specific pharmacist that's registered, it has to be logged. It's a whole can of worms. I think a couple things about that. First, if you want to stock those disposal bags, I'd love to figure out a way to make those widely available. Again, they're not that expensive. I can't tell you our pricing, but they're well under $5. So being able to give patients that right away and they can dispose of it right there. Encouraging to have a drop box. So if your clinic is next to a pharmacy, having them drop it off, that can work very effectively as well. So I think those are all options there. But yeah, don't take them back.
Okay, so I had an experience with oxycodone, a personal experience. I had surgery. Post-op, I was prescribed, I think, 5 milligram oxycodone every 4 hours for pain. So I'm healthy, non-smoker, very active, and my oxygen, according to Fitbit's, 95% most of the time and through the night. And I was desetting to the mid-80s during the day while wide awake because I was forgetting to breathe, and I was setting off the alarm, and they would come in and say, Becky, take 3 or 4 deep breaths. And I was back in the 90s. In this day and age of wearable technology where we can monitor the oxygen level and set alarms, and we've got probably a lot of patients with undiagnosed sleep apnea who also, by the way, have a benzo or they drink and they take these painkillers, and more is better, right? So I think a lot of the accidental deaths could be prevented if we use the monitoring. Is there any move afoot that we can see to monitor people that are on opioids that cause respiratory depression? And I ended up on just Tylenol, and it wasn't enough. So maybe they should have known about other alternatives. Anyway.
No, I think those are great points. I think the idea of monitoring patients at home is I think a broader theme that we're seeing across lots of health, right? So again, those of you who manage CHF or other diseases like that, like weight monitoring, telemedicine, those kinds of things, integrating those things, I think is right on. I think we do have a cultural change to deal with. In our nurses often are encouraging patients, okay, just take the payments. And so then the patients just perceive that as the way to go. And then when they go home, we shift and we're like, oh, no, don't take the payments. So I think there's a lot of cultural shifts that we have to do about how we approach pain and frankly manage pain. But I think some of those ideas you propose are really great. So that's for the next grant. Any other questions? Oh, great.
Hi, I'm Kirsten Baca. I actually was the pain doctor that gave the presentation on buprenorphine yesterday. And I'm not sure what I'm going to say at this moment, but I appreciate that we all need to understand this medication more. And I just want to throw out there that it's a very useful medication even in the perioperative period. And one of the important things that we're learning about buprenorphine, because it's sat ignored for a long time or kind of relegated to opioid use disorder, but one of the things we're learning is that we can safely continue it during the operative period and use it for post-operative pain management quite successfully. Where we run into problems is where we inadvertently wean or purposely take the patient completely off of their buprenorphine in preparation for surgery, the thought being that a mu-opioid receptor agonist is all that we can use to treat pain. That's not true. And when you withdraw somebody from buprenorphine, let's say they're on 8 milligrams a day, that could be somewhere in the range of a 200, 300 morphine equivalent. That's quite an abrupt withdrawal and quite a deficit that one needs to make up during the perioperative period for just pain control of chronic pain, not to mention acute pain, which needs to also be treated. So protocols are being developed across the country for managing perioperative buprenorphine, and it looks like continuing the dose to the day of surgery as it was written, and then post-surgery that afternoon or evening, starting it maybe 3 or 4 times a day, same dose but divided, will be kind of the optimal analgesic approach. And then, of course, on top of that, treating with pure mu-opioid receptor agonists like IV morphine, PCA dilaudid pump, and transferring to oxycodone for that window of acute pain. But yeah, having a DEA waiver is very helpful when you're first learning how to use this medicine, or at least having training in transitioning if somebody's on pure MOR versus you want to put them on something like buprenorphine. So I want to echo what you said. It's important to have a clear understanding of the medication, and I'm glad it was brought up, but I do think it really does have a great role in the perioperative period.
I agree 100%. It's been, I think, so about 20% of our patients that are coming in for surgery have at least a prior exposure to opioids, and they're going to have some resistance to it. And then a smaller percentage, but a very real percentage, have, long-term drugs on board, either methadone, buprenorphine, things like that. And it's been an uphill struggle for both us getting more comfortable prescribing that in an inpatient setting, or using things like the anesthesiologists now are using methadone more commonly intraoperatively to try to keep that basal level that the patients need. I echo 100% what you said. You're spot on. We're trying to teach our trainees, keep those medicines going. They often feel very comfortable. So what we're establishing is a group of anesthesiologists that see the patients beforehand, work through them and follow them afterwards to help with these higher doses of narcotics and help who are comfortable with buprenorphine in the perioperative setting. And then again, I would say, as a surgeon, we should be talking to you before and after. I try to talk to all my patients who have a pain contract or pain medicine doc so that we're on the same page about how the handoff happens coming into the hospital and coming out of the hospital as well. So
Perfect. Thank you.
You are spot on.
Thank you.